Hi, I'm Bob Eckel. I'm a professor emeritus of medicine at the University of Colorado Andrews Medical Campus, which is east of Denver in Aurora. And I've been in that setting for over 40 years. I'm an endocrinologist, but I kind of cross-dress as a preventive cardiologist. And I've been a co-chair for the Cardiometabolic Health Congress now for 17 years. So it's been my privilege to be part of this on an ongoing basis. And today, working with me in this webinar is Dr. Eckel and Harrison. Stephen, why don't you tell us about yourself a bit?
Yeah, thanks, Bob. So I am a gastroenterologist and transplant hepatologist that is currently practicing in San Antonio, Texas. I am a visiting professor of hepatology at the Radcliffe Department of Medicine, Oxford University in the UK. So I spend some time there for that university as well. My main work is focused on drug development for fatty liver disease. So I run a clinical trial shop here in San Antonio, and I work with pharmaceutical companies around the world to develop their compounds specifically for the treatment of NASH.
Well, good. Well, Dr. Harrison and I shared the podium in Boston this year at the 17th Annual Cardiometabolic Health Congress, and I think this is a spin-off on that time we had together there. So, Stephen, I can't help but look at the book behind you, Make My Liver Great Again. So, in terms of someone who sees a lot of patients that have cardiometabolic diseases, ultimately, I've been impressed with the increasing need to assess their liver, and that begins kind of naively with liver function. So, in terms of the primary care physician or maybe the non-hepatologist, the gastroenterologist, it's an exception to this, but ultimately the cardiologist, the endocrinologist, the primary care doc, she or he needs to know what to do next. I mean, we're concerned about the advancement of liver disease that goes beyond simply fat accumulation. So, historically we get an AST and an ALT, and that's pretty naive, isn't it? So the idea of progressing past that, or even starting anew with the new guidelines, what are your thoughts about that? How we can inform the primary care doc and other subspecialists in terms of how to approach this very, very common problem of our time?
Yeah, I think it starts with an awareness, realizing that fatty liver disease is a disease. Non-alcoholic fatty liver is the #1 liver disease in the world, certainly the #1 in the United States. It's now the #2 reason for liver transplant if you look at all comers. If you focus on women over the age of 50, it's #1. If you look at liver kidney transplant, it is #1. So it is a major, major ordeal, and we need to wrap our brains around the fact that this is something that is not benign, that in fact there are a subgroup of people that will develop steatohepatitis and progress into a cirrhotic phenotype. So how do we identify those patients? And this is something we've spent quite a bit of time working on, trying to hone in on a simple way to identify those patients at greatest risk of disease progression. So the AGA, American Gastroenterological Association, in 2021 published an algorithm for evaluating these patients. And more recently, the AASLD guidance document was presented in its most recent updated form at our liver meeting earlier last month in November. It's December 1st now. It's yet to be published, but to give you a little highlight of that, both guidance documents look at a very simple test called a FIB-4, which is an online calculated form that includes ALT, AST, age, and platelet count. And who should get that test? Well, if you look at the AGA guidance, people with 2 or more metabolic risk factors, if you have fatty liver on imaging, or elevated liver chemistry test, that's where you start. And I think we could also include, if you're a diabetic, that in and of itself gets you to the point where you would check a FIB-4. Now, both guidance documents say less than 1.3 for that number, you're okay to just follow the patient with diet and lifestyle recommendations. If it's greater than 2.67, that's the upper bound, then that indicates a high degree of risk for advanced liver disease, and those patients should be referred on for further care. If you're in the middle, between 1.3 and 2.67, that's where both guidance documents recommend a second non-invasive assessment. So generally, yeah.
sorry to interrupt, but that takes us on to maybe more assessment of the anatomy, right? The FibroScan perhaps would be indicated in those intermediate risk patients. Is that
That's
true?
absolutely right. Absolutely right. Yeah. So FibroScan, while it is growing in its utilization around the country, the AASLD recognizes that not everybody has access to a FibroScan.
Yeah.
And so they're recommending alternatively the ELF score, ELF score, which is now readily available through LabCorp. So if
Okay.
you're in that indeterminate zone, do a FibroScan or an ELF score, and the cutoffs for this are less than 8 for a FibroScan or less than 7.7 for an ELF score, throw you into the low risk category. And now you're just diet and lifestyle modification. Repeat the test in a couple of years. If you're higher than that, that's where we ask that you refer them on for further evaluation, which very likely would include an MRI at that point.
Tell us what the ELF score is, Steve.
Yeah, sure. That's a good. Yeah, I'm just picturing the movie Elf in the background, right? So ELF score is a composite of 3 fibrosis biomarkers. So hyaluronic acid,
Okay.
TIMP1, and the third is P3NP. So those 3 fibrosis biomarkers are a composite that rolled up into one gives you the ELF score. And a lot of work has been done using it as a prognostic factor for patients with advanced liver disease. So what we know is that if it's greater than 11.3, that predicts the probability of cirrhosis very highly.
I see. Okay.
But we use the cutoffs in the AASLD guidance are less than 7.7, don't worry. Greater than 9.8, Houston, we may have a problem. Let's look at this a little bit closer. So that's where the ELF cutoffs kind of fall. Less than 7.7, good to go. Greater than 9.8, let's refer that patient. Greater than 11.3, high likelihood of cirrhosis.
So, what are the issues related to assessing patients' liver disease, the extent of it using a FibroScan or the ELF score relates to fibrosis? But, when we think of NASH, I think of it maybe mechanistically naively, but I'm thinking about inflammation. So the idea here is that inflammation ultimately results in fibrosis, right? I mean, could there be degrees of inflammation where in fact ballooning and or fibrosis are not present yet? And in fact, we maybe need to diagnose these people at an earlier stage?
Yeah, that's a great point. So just thinking very pragmatically about the liver wants to heal itself. It is like the skin in that regard. You cut the skin, you get a scab. You injure the liver, you get a scab. We just don't call it a scab. It's the same fibrogenic process, upregulation of stellate cells in the liver that lay down this collagen. So it all starts with injury. So that's the inflammation you're speaking of. And oftentimes in the setting of fatty liver, we're going to start with a lipotoxic environment. Free fatty acids are very toxic to the liver. And so that's going to set up an injury pattern that's going to bring white cells into the liver. So when we do a liver biopsy and we see lymphocytes or plasma cells or neutrophils, that's what we call a hepatitis, right? Viruses can cause it. Autoimmune diseases can cause it. So fatty liver can cause it as well. And it doesn't necessarily mean that we're going to see fibrosis right off the bat, or we're going to see dying ballooned hepatocytes. To your point is well taken. In the early stages of the disease, we might just see a little inflammation. So but over time, what happens is inflammation leads to injury leads to scar tissue. And if left unabated, that's what progresses on average 1 stage every 7 years towards cirrhosis.
One of the problems I think that the referring physician has is ultimately knowing what steps they can take therapeutically before maybe sending a patient on to you. So, things like pioglitazone and vitamin E and metformin and other things are out there. What is your advice in terms of taking initial steps therapeutically before we really have adequately assessed the extent of liver disease with the current therapies that are available?
Yeah, that's another great point. So the AASLD guidance document actually will outline the utilization of currently available therapies for an off-label indication to treat fatty liver.
All off-label, yeah.
All off-label. There are no FDA-approved treatments
Right.
yet. And I say yet with a capital YET, because this month we should hear if a drug meets their primary endpoint on a phase 3 registrational trial. If it does, very, very likely that will be the first FDA-approved treatment for NASH. You file the NDA, it takes 6 months. You're looking at next Q4 before we would have that therapy available. But it's good news for the field to be able to finally get something across the finish line. So fingers crossed that we do that. In the meantime, foundationally, we know that weight loss is the gold standard for treating this disease. 10% weight loss tends to fix everything: fibrosis, inflammation, ballooning, fat, all of that. You do get gradations of improvement with something as simple as 2 to 3% weight loss, but really to get after the fibrosis and the ballooning, you need to get up to the 10% number. Now, that's good news for people that weigh 300 pounds. You don't have to get Arnold Schwarzenegger looking to have significant change. You go from 300 to 270, you're still obese, you're still overweight, but you've left a big fat dent on this planet in the name of your fatty liver. So that's good. How do we get there if you're unable to achieve that with lifestyle modification? Well, there are drugs that are very effective for weight loss right now. These are the GLP-1, the GLP-1 GIPs, the GLP-1 glucagon agonist. Tirzepatide is out there, semaglutide is out there, liraglutide is out there. So those are therapies that, in an off-label indication, targeting the diabetes or the obesity, would also have a synergistic impact on underlying liver disease. Metformin doesn't really do anything for fatty liver. Ursodiol doesn't as well. The SGLT2s actually do help with weight loss a small degree. They also have impacts on fatty liver to a certain degree. I generally look at the SGLT2s as an additive benefit above and beyond, because of the heart failure improvement that we've seen with that drug. And we know the number one killer of a NASH patient is heart disease. And very often we see right-sided heart failure, diastolic dysfunction in these patients. And so adding an SGLT2 might not be a bad idea if the diabetes needs a little bit better control than, say, something just with metformin or diet alone.
So I'd like to open that one door a little bit further, Stephen, the idea of fatty liver disease, particularly more advanced forms, being associated with cardiovascular disease. I mean, increasingly this topic is part of the Cardiometabolic Health Congress. And the reason it is because of, to some extent, an increasing independent relationship to cardiovascular disease outcomes. So your thoughts about that relationship and also mechanisms that relate one to the other.
Yeah, I mean, I think there absolutely is a relationship. What we're struggling with in our field is a bit of what comes first, the chicken or the egg. Is it the same mechanisms that are driving liver disease, that drive the heart disease? Does liver inflammation set us up for plaque rupture? Is there a situation where the liver is deriving inflammatory mediators that have impacts on endothelial dysfunction downstream? That's some of the issues we're trying to work out right now. But this harkens way, way back to Archimedes' days, where essentially, the idea of the bile being, the lifeblood of the body, and all the things that are in bile that could impact, what
he
it
sounds
is.
like a hepatologist now, doesn't he? Okay, go.
Yeah, I mean, it all starts in the liver, right? You go to a barber, you get a haircut. You go to a liver doc, everything's related to the liver, right? Everything's a nail and we're a hammer.
There you go. Okay.
But essentially, there is a link. What's causing it exactly, we're unsure. But it is clear that fatty liver disease is inextricably linked to cardiometabolic disease. And we want in our therapeutic armamentarium to tackle both. We don't want to be so myopic as a liver doctor that we're solely focused on fibrosis and inflammation in the liver. We want to have a therapy
Sure.
that gets at that, but also impacts cardiometabolic disease, the lipoproteins, the cardiac disease itself. So the diabetes, we want to have an ideal therapy that gets after all of that.
Now he's speaking my language. So just in closing then, Stephen, this whole issue of drug development, I kind of throw out a number that has no data behind it. There must be 40 or 50 companies out there working on drugs to modify the natural history of fatty liver disease. And it's now, what's it called now? Metabolic liver disease? There's a new term that you're using.
Well, we're working hard on that right now. We're using a very formal Delphi process to try to get at it, but it looks like the overarching name might change to steatotic liver disease, and there will be phenotypes underneath that. Yeah.
You guys always make it more complicated. Anyway, think out loud for me a little bit about drugs under development, meaning classes of drugs. I mean, there are drugs that modify inflammation, there are drugs that modify fibrosis, there may be drugs that relate to regeneration. I mean, what's going on out there, and what can we look forward to? And you might mention in a little bit more detail what the FDA is considering right now.
Yeah, sure. There are 5 drugs in phase 3 development right now. One is on hold. That's a drug that modifies de novo lipogenesis. That's on hold. The ones that have actually read out phase 3, there's only one. That's a beta-cholic acid, which is an FXR agonist, which has pleiotropic effects in the liver to really focus on inflammation and to some degree fibrosis. They just read out a reanalysis of their phase 3 trial, showed essentially the same treatment effect delta, around 11 to 12% on fibrosis. They have more long-term outcome data looking at safety. There was an issue with LDL increase, an issue with gallstone formation, and some others that really, I think, caused the FDA to pause a little bit and say, give us some more safety data over time. They've done that now. They've said they're refiling by the end of this year. So that's one. The other one is a thyroid hormone receptor beta agonist. Right. That is the one I mentioned a moment ago that is reading out this month, their phase 3 registrational trial. They've already read out a phase 3 trial on safety and tolerability. It's a once a day, very safe, very well tolerated drug that basically takes a hypothyroid liver and makes it euthyroid. It allows the liver to convert T4 to T3. In so doing, you upregulate the burning of fatty acids through beta oxidation. Mitochondrial health comes back online. And then you have 2 drugs that are in phase 3 enrolling the registration trial right now. One is lanifibranor, which is a pan-PPAR agonist. So it has some PPAR delta activity, some PPAR alpha activity, and some PPAR gamma activity. You know PPAR gamma is because of pioglitazone. So it has a similar type effect there. Concern with that drug is really, it's very, very effective on NASH resolution, very effective on hemoglobin A1C improvement, even on lipids. But its issue is we're just following the weight gain there because we see that with pioglitazone, there is some gamma activity. And then finally, semaglutide, the GLP-1 by Novo Nordisk is in phase 3, already approved for obesity and diabetes, now going after a NASH indication as well. So if you notice a theme there, all those are drugs that are working on metabolism. So they're working way upstream, trying to hit the drivers of NASH. They're getting after insulin resistance, free fatty acid flux, working to make the liver better at handling lipids like the THR beta or the FXR. In the pipeline, we've got some fantastic drugs. The one I'll mention that I'm most excited about is the FGF21 agonist.
Okay, I was going to ask you about that. Good.
Yeah. So FGF21 is an endogenous metabolic hormone that regulates metabolism, glucose and lipoprotein metabolism as well. The problem is its half-life is very, very short, about 2 hours. So pharmaceutical companies have tweaked that hormone by pegylating it, by putting fusion protein together. And what we know about that is if we can get it to stay around for, on average, a half-life of a couple days to up to a week, that it's going to work on 3 different receptors: beta-klotho FGFR1, 2, and 3C, and that works on insulin resistance. So it has almost like a PPAR gamma effect without the side effects of weight gain, in the sense that it improves insulin sensitivity. It also works in the liver to upregulate beta oxidation and downregulate de novo lipogenesis. So it kind of does all the things we want it to do. Not all FGF21s are created equal. They're widely different depending on their chemical scaffolding, how well they bind to the receptor, et cetera. Their side effect profiles are generally similar in that they have GI-related side effects, from nausea to loose stools, et cetera. So more to come there. But the phase 2b trial results of one particular FGF21 called efruxifermin just was presented by myself at AASLD last month.
Okay.
Very, very positive results. 24 weeks of treatment. If you look at NASH resolution, 76% in the high dose group versus around 15% in placebo, giving you a treatment effect delta of around 61% with 24 weeks of therapy.
Wow.
So very, very positive news. If you look at the more stringent endpoint of improving NASH and fibrosis, it was 41% for the high dose 50 milligram versus 5% for placebo, treatment effect delta 36%. So the future looks bright for the field of NASH. Where will those drugs be used? I think, in my own mind, the injectables are going to be a little more potent, but have more side effects. So I think I would use them as induction agents, hit them hard for 6 months, get patients under control, and switch them to something that's oral and better tolerated for the long run.
So it sounds like a staged therapy is something we might anticipate there. Well, great. This has been a fantastic discussion with a leader in hepatology and non-alcoholic fatty liver disease, to be renamed, it sounds like. Just a few final comments. I think, as an endocrinologist, I've used pioglitazone in patients with fatty liver disease at lower doses where the weight gain hasn't been so great, and the whole effect on the bone, et cetera, has been modified favorably. So I think that's one option for the practitioner right now to think about, to consider. And just to clarify the vitamin E story, that was either in patients with or without diabetes. Which outcome can we look at vitamin E for?
Well, actually, that's a great point. I didn't allude to that when you talked about therapies that are off-label. So pioglitazone, for sure. Ken Kuzi and I published the first paper on that in New England Journal back in 2006.
Right.
Very effective. I love it at the lower doses, 15, 30 milligrams.
Yeah.
Now, the vitamin E story, it was studied in non-diabetic, non-cirrhotic patients. And so that's what it's indicated for, at doses of 800 to 1,000 international units a day. Having said that, I use it all day long in diabetics and in cirrhotics. It just wasn't studied in that, so that can't.
I see.
Now, remember, that was never put through the FDA approval process.
Right.
It was one study called the Pivens trial, published New England Journal in 2010, that made it into the AASLD practice guidance document. So, I mean, it's been studied in diabetics since then and found to be effective. I don't think we've had a study in cirrhotics, but anecdotally, I don't see any issue with it. I use it quite frequently. The big thing with vitamin E, you just have to tell your patients, look, small chance of prostate cancer risk. The number needed to treat is outrageously high to get that. There's an issue with hemorrhagic CVA that's been published before, because remember, high doses vitamin E could have an impact on blood clotting. So those are the two big issues. I just tell my patients, look, I don't mind putting you on this. Just you need to be aware that these two things have been linked to that in long-term treatment with high doses.
Okay, well, let's close. I want to thank Dr. Stephen Harrison for an outstanding presentation of the update on the approach to non-alcoholic fatty liver disease. And hopefully this information will be useful to you in your practice of cardiometabolic medicine. Thank you very much, Stephen.
Thank you.